Welcome back to our brain imaging anatomy course. Today will be the last lecture of brain imaging anatomy. Then we will move on to discuss the head and neck and the other parts of the body. We have discussed the ventricular system and CSF spaces. We covered the blood supply to the brain and the venous sinuses. We talked about the basal nuclei and major white matter tracts. And we talked about the cerebrum with its 4 lobes. So today we will be covering the cerebellum, the cranial nerves, pituitary gland, and the juxta-sellar structures. Starting with the cerebellum, this is the location of the cerebellum, beneath the tentorium cerebelli and anterior to the brainstem. Cerebellum, this name means the little brain. That is to compare it to the cerebrum, which is the large brain. It sits at the base of the brain in the posterior cranial fossa. We know that the cranium is divided into 3 fossas: the anterior, middle, and posterior. So most of the posterior cranial fossa is occupied by the cerebellum. It lies below the tentorium cerebelli and behind the brainstem. This is how the cerebellum looks on the real images. This is a T1 MR image of the brain. It shows the location and the normal configuration of the cerebellum. So it lies within the posterior cranial fossa, just below the occipital bone. Superiorly, there is the tentorium cerebelli, which is a reflection of the dura mater that separates the cerebrum from the cerebellum. Anteriorly, there is the 4th ventricle and the brainstem. The gross anatomy of cerebellum has many specific features. There are 3 surfaces of the cerebellum. The anterior surface, that is the surface that faces the petrous bone. So it's also called the petrosal surface. The superior surface, we already saw this one in the previous image. That's the tentorial surface, this surface. The surface that faces the tentorium cerebelli. And the inferior surface, this is the suboccipital surface, this surface. The surface that is just beneath the occipital bone. And there are also 3 fissures. These are the primary or tentorial fissure, the horizontal or petrosal fissure, the peribiventral or peripyramidal. This is also called suboccipital fissure. We will see these fissures in the next few slides. Cerebellum is also divided into 2 hemispheres, same as the cerebrum, and it has a single median vermis lying within the middle part of the cerebellum. This is an axial image of the brain. It shows the location of the cerebellum with the relation to the anterior structures, including the brainstem. So this is this section was taken at the level of medulla oblongata. So this is the medulla oblongata, and this is the cerebellum. This is the left cerebellar hemisphere, and this is the right cerebellar hemisphere. At the middle part is the cerebellar vermis. This is a coronal view of the cerebrum and cerebellum. This is the cerebellum. It lies below the tentorium cerebelli, which is this thin dura reflection that separates the cerebrum from cerebellum. This is the left cerebellar hemisphere, the right cerebellar hemisphere, the cerebellar vermis at the middle, and the cerebellar tonsil, which is the lowermost part of the cerebellum. Here we talk a little bit about the cerebellar vermis. It is divided into 9 lobules in a clockwise rotation, looking at the patient sagittally from his left. And these lobules are separated into groups by the fissures that we already talked about. These lobules are confusing a little bit, but the good news is that you don't need to remember all of them, and they are not that much practical when you are interpreting the images. The 9 lobules include the lingula, the central lobule, the culmen, the declive, folium, tuber, pyramid, uvula, and nodulus. This is a sagittal image magnified to show the 9 lobules of the cerebellar vermis in a clockwise rotation, starting from the lingula here, the central lobule, and the culmen, and this is here the primary fissure or tentorial fissure. It's extending from the tentorium cerebelli vertically. Then the declive, the folium, and then the horizontal fissure. This is oriented horizontally. Then this is the tuber. This is the prepyramidal fissure. After that is the pyramid, lobule, the uvula, and the nodule or nodulus. The lowermost part is the tonsils of the cerebellum. The cerebellum is connected to the brainstem with several pairs of peduncles. There are 3 pairs of peduncles. The superior cerebellar peduncles, these are the peduncles that connect the cerebellum with the midbrain, the highermost part of the brainstem. Then the middle cerebellar peduncles, these are the peduncles that connect the cerebellum with the pons. And then the inferior cerebellar peduncles, they connect the cerebellum to the medulla oblongata inferiorly. This image here is to show the superior cerebellar peduncle. It's a very thin peduncle actually here. And this is the middle cerebellar peduncle. It's the largest cerebellar peduncle. But unfortunately in this image the section was taken a little bit far from the pons. This peduncle is supposed to be connecting the cerebellum to the pons. And this is the location of inferior cerebellar peduncle. It connects the cerebellar hemispheres with the medulla oblongata. The CSF cisterns that surrounds the cerebellum, we already talked about some of them. I think you still remember these. We talked about the cisterna magna, right? We said that this is the largest CSF cistern. And then the quadrigeminal plate cistern. Here we add the cerebellopontine angle cistern. This cistern lies at the cerebellopontine angle, the angle between the cerebellum and the pons. And the superior cerebellar cistern, this cistern lies above the cerebellum. We saw these images before, so we review here the CSF cisterns at the base of skull. Here we have the suprasellar cistern above the sella turcica. This is the interpeduncular cistern between the 2 cerebral peduncles. This is the ambient cistern and the quadrigeminal cistern. This is the 4th ventricle anterior to the cerebellum and the prepontine cistern here. And more superiorly is the cerebellopontine angle cistern at the CPA. This is a sagittal image. This is the cisterna magna, lies just posterior and inferior to the cerebellum, the largest CSF cistern. And the quadrigeminal cistern here lies posteriorly to the quadrigeminal plate. And the superior cerebellar cistern. More anterior here we have the suprasellar cistern above the sella turcica. We will talk about the sella turcica and the surrounding structures shortly. This is the interpeduncular cistern and the prepontine cistern. The cerebellum is supplied via the vertebro-basilar system, which gives 3 large branches that supplies the cerebellum. These branches are the superior cerebellar artery superiorly. This is a branch of the distal basilar artery, just before the bifurcation to form the posterior cerebral arteries. Then the ICA or anterior inferior cerebellar artery. This is a branch of the proximal part of the basilar artery. The PICA, the posterior inferior cerebellar artery. This is a branch of the distal vertebral artery before merging to form the basilar artery. This image here is to show the 3 major blood supply to the cerebellum. Starting from the PICA, which is the branch that is given by the vertebral artery, the distal part of the vertebral artery, before the merge of the two vertebral arteries to form the basilar artery. The basilar artery will also give two branches. At the proximal part, it will give the ICA, the anterior inferior, which will supplies the anterior inferior part of the cerebellum. And the SCA, the superior cerebellar artery, which is branching from the distal part of the basilar artery and supplies the superior part of the cerebellum. This is the DSA image showing the PICA, ICA, and SCA from down to up. Here we have highlighted the territories that are supplied by several blood supply of the cerebellum. So the upper part or the superior part is supplied by superior cerebellar artery, right? Yeah, it's clear. Then the inferior part is divided into two sections. The anterior part is supplied by ICA, right? The anterior inferior cerebellar artery, and the posterior part PICA, right? Yeah, posterior inferior cerebellar artery. This is a more superior section to show the territory of the superior cerebellar artery. So this is the superior part of the cerebellum, and this is the brainstem, which is supplied by some penetrating arteries. This is an inferior section showing the anterior area of the cerebellum, which is supplied by ICA, right? Yeah, the anterior inferior cerebellar artery, and the posterior part, which is supplied by PICA, yeah, posterior inferior cerebellar artery. So now you already know the anatomy of the cerebellum, right? What do you see on these images?
Don't you see?
Sorry?
What don't you see?
Yeah, what don't you see in this image? If you do see something, tell me. If you don't see something, tell me. What is the location of the cerebellum? This is the location of the cerebellum, right? Is this the cerebellum? No, it doesn't seem like cerebellum, right? Cerebellum should be iso-intense to the cerebrum, right? Yeah, and it has folia and it has some specific features and structures. But what we see here is a homogeneous hypodense area, right? So this is fluid mainly. This is CSF. Then what is the cerebellum? This is a coronal image and this is axial image. Even on the axial image, we don't see anything at the cerebellar area. We just see here the brainstem, part of the brainstem here. So, where is the cerebellum? It was not formed, right? Yeah, this is a case of cerebellar agenesis. It means that the cerebellum was never formed. So, this person has been born without cerebellum. Let's have a look at this image. Do you see any abnormality? The cerebellum is here, right?
Yeah.
So it's not absent in this case. But is there any other abnormality?
Yeah, it's
Yeah.
the tonsils are extended through the foramen magnum because the compartment is small.
Yeah, that's true. Yeah. And if you draw this line, it's more clear, right?
Yeah.
This is called the basion-obliteon line. As Dr. Joy said, yeah, that's true. The cerebellar tonsils are protruding through the foramen magnum into the spinal canal. And this is normal or abnormal?
Normal.
Yeah. It is abnormal when it exceeds 3 to 5 millimeters. So the variant anatomy of the cerebellum mainly are the cerebellar agenesis, we already saw that case, and the tonsillar ectopia. Tonsillar ectopia, it means that there is asymptomatic protrusion of the cerebellar tonsils through the foramen magnum by no more than 3 to 5 millimeters. What if it is more than 5 millimeters or more than 3 millimeters in some occasions? It's called what?
it's called cranial malformation.
Yeah, it's called tonsillar herniation, which could be a part of Chiari malformations. Yes, that's true. So this is a case of Chiari malformation. We move on to talk about the cranial nerves. I think you still remember the cranial nerves, right? We have 12 pairs of cranial nerves. They are called cranial nerves because they are originating from the cerebrum or the brainstem, and they leave the central nervous system through some cranial foramen rather than through the spine. The nerves that are leaving the central nervous system from the spine are called the spinal nerves, right? But these are cranial nerves. They come out before the spine even extend. See, these are some mnemonics to remember the cranial nerves. You may find them useful. For me, I don't really use them. Yeah, the cranial nerves are 12 pairs, starting from the cranial nerve number 1, which is the olfactory nerve, right? The nerve that carries the signal of odor sensation. Cranial nerve number 2, optic nerve. 3, oculomotor nerve. 4, trochlear nerve. 5th, trigeminal nerve. 6th, abducens nerve. 7th, facial nerve. I think you're familiar with this one, right? Then 8th, auditory or vestibulocochlear nerve. Then 9th, glossopharyngeal nerve. The 10th is the vagus nerve. The 11th is the spinal accessory nerve, and the 12th is hypoglossal nerve. So here I have some bad news for you and some good news. So do you want to hear the bad news or the good news about these cranial nerves first?
Good news first.
The good news first. If I tell you the good news, the bad news will be useless. Okay, the good news is, although they are many, but on the imaging of the brain, they are very subtle. Most of them, they are very subtle. It means that you cannot identify them unless there is some pathology that makes them abnormally enlarged. Just few of them are large and can be identified. We will know them. Yeah, so this is the good news. The bad news that they are a lot, right? So this figure here is to show the originations of each of these cranial nerves. This is the cranial nerve number 1, olfactory. The optic nerve forming the optic chiasm. These two nerves are originating from the cerebrum. These are the only two cranial nerves that are originating from the cerebrum. The others are originating from the brainstem, including the midbrain, the pons, and the medulla oblongata. So here, this is the cranial nerve number 3, the oculomotor. This is number 4, trochlear nerve. The trigeminal nerve, the large one, right? So this is one of the largest cranial nerves that can be easily identified on the imaging, especially MRI. This is number 7, facial nerve. This is 8th, vestibulocochlear nerve. And this is number 6, the abducens. Lower down, we have the glossopharyngeal, the vagus, the accessory, and the hypoglossal. According to their origin, we have two cranial nerves that are originating from the cerebrum. These are cranial nerve number 1 and 2, the olfactory and optic nerves. This is the location of olfactory bulb and olfactory nerve, cranial nerve number 1. It lies just below the rectus gyrus of the frontal lobe. This is a special MRI sequence. It's called steady state free precision image or sequence. This sequence is used to give a high resolution between the isodense, the iso-intense signal of the cranial nerves and the hyper-intense signal of the CSF. Therefore, we can see the cranial nerves passing through the CSF sisters clearly. This is the location of cranial nerve number 1, olfactory nerve. As we said, it's lying below the rectus gyrus of the frontal lobe. It's very subtle, right? Yeah. This is the optic nerve, cranial nerve number 1. This is a large one, an obvious one. It can be seen on CT and MRI. And it has a very long course. So here, the intraocular segment. Here is the intracanalicular within the canal, and intracranial segments. After it enters the cranium, it gives the optic chiasm here, and then the optic tracts, which will extend all the way to the occipital nerves. So this is the optic nerve. This is one of the largest cranial nerves, which can be easily identified on brain imaging. The cranial nerves that are originating from the midbrain are two pairs, the oculomotor and the trochlea, number 3 and number 4. This figure shows the nuclei of the cranial nerves at the brainstem. So we have 3 and 4 in the midbrain. We have 5, 6, 7, and 8 at the pons, and 9, 10, 11, 12 at the medulla oblongata. Cranial nerve number 3, the oculomotor, emerging from the medial aspect of the cerebral peduncle. As we see here, this is a standard T1 MRI. So this is cranial nerve number 3, originating from this medial aspect of the cerebral peduncle. This is the steady-state free precision sequence to show the location of oculomotor nerve, the cranial nerve number 3. The cranial nerve number 3 lies between the superior cerebellar artery here and the posterior cerebral artery. If you remember, we said that the superior cerebellar artery is branching from the distal part of the basal artery, right? So this is the distal part of the basal artery. Between the branch of superior cerebellar artery and the bifurcation of basal artery to form the posterior cerebral artery is the cranial nerve number 3. So this is the location where we find the cranial nerve number 3. It lies within these two branches. It means that when there is any abnormality or mass or whatever with this nerve, it will cause splaying of this distance, right? Here we have the cranial nerve number 4, the trochlear nerve, lying within the ambient system here. This thin structure is the trochlear nerve. 4 pairs of cranial nerves are originating from the pons. These are number 5, 6, 7, and 8. Trigeminal nerve, the abducens nerve, the facial nerve, and the vestibulocochlear nerve. This configuration again to show the nuclei of these 4 pairs of cranial nerves that are originating from the pons. We start with the trigeminal nerve. This is a large cranial nerve that can be clearly identified on imaging. It's originating from this part of the pons. This is SSFP MRI sequence to show the trigeminal nerve. We can see it clearly here on the right side. On the left side, it's not seen because the section is not symmetrical. Yeah, this is it. So as we see that this MRI sequence, it provides a good resolution between these nerves and the high signal intensity of the CSF. So we can see these nerves passing through these CSF systems clearly. This is cranial nerve number 6. It's very subtle, very thin. This is the abducens nerve. So these subtle ones, if you don't have this kind of MRI sequences and they are normal, usually you will not see them. Facial nerve number 7 and 8. These are 2 cranial nerves that are emerging from the CPA, the cerebellopontine angle. They come out in a parallel course. So they are coming together. Then they will leave here after this. This is cranial nerve number 6, if you remember, abducens, very subtle one. Lastly, the cranial nerves that are originating from the medulla oblongata, they are 4 pairs, 9, 10, 11, and 12. These are the glossopharyngeal nerves, the vagus nerves, the accessory nerves, and the hypoglossal nerves. and this is the configuration to show their nuclei within the medulla oblongata. This is glossopharyngeal nerve, the cranial nerve number 9, very thin, very tall or long one here. This is glossopharyngeal nerve. Here. And more posteriorly is the vagus nerve. These are also very subtle cranial nerves to be seen on the images. Finally, the accessory nerve, cranial nerve number 11, and hypoglossal nerve, the cranial nerve number 12. So this is a spinal root of the accessory nerve, cranial nerve number 11, and this is the hypoglossal nerve, cranial nerve number 12. It was very difficult to me to find these images because these cranial nerves, these thin ones, are very difficult to detect on the image unless you have these kind of like high resolution MRI sequences. Then we'll move on to talk about the pituitary gland and the juxta-sellar structures. Pituitary gland sits up at the base of skull, as we know, within a concavity within the sphenoid bone. This concavity is called the sella turcica or the pituitary fossa. This pituitary fossa lies immediately below the hypothalamus and the optic chiasm. Practically, the pituitary gland is divided into two parts, the anterior part and the posterior part. And we will see how we differentiate these two sections on the image. This is a magnified image, MRI T1 weighted, to show the pituitary gland with the surrounding structures. So this is the sella turcica, concavity within the sphenoidal bone. This is the sphenoid sinus. This is the anterior part of the pituitary gland, which is iso-intense to the brain tissue. And the posterior part is slightly hyperintense. We will know why it's hyperintense and what does this mean, and what does it mean when we lose this hyperintensity. This is the pituitary stalk or the infundibulum that connects the pituitary gland to the hypothalamus. This is the thalamus, and this section here is the hypothalamus. Posteriorly, we have the interpeduncular cistern, the prepontine cistern, and the brainstem. The posterior pituitary bright spot is an MRI feature of normal pituitary gland. Why it's bright on MRI? That's because this area of the pituitary gland is the area where is the antidiuretic hormone and the vasopressin are stored. And these hormones have the ability to cause T1 shortening. It means hyperintensity on T1 images. But this posterior pituitary bright spot is identified in can be identified in 50 to 100% of the people or of the patients or population. This is because there are some people who have ectopic posterior pituitary, which means that the posterior pituitary is located somewhere else, not at this area. And some other pathologic changes that cause this posterior spot posterior pituitary bright spot to be disappeared is the central diabetes insipidus. This is when there is a lack of antidiuretic hormone that causes the central diabetes insipidus. This is another image, another illustration to show the relation of the pituitary gland with the surrounding structures. So this is the pituitary gland. This is this MRI image is post contrast. That's why we see the whole pituitary gland is bright. This is the infundibulum. This green circle here refers to the optic chiasm. And these two recesses are the supraoptic recess and the infundibular recess. If you remember the configuration of third ventricle when we talked about ventricular system in the first lecture, third ventricle had like two anterior small holes or small recesses. These are the two small recesses, the supraoptic recess and the infundibular recess. This is a coronal image with illustrations of the pituitary gland, infundibulum, optic chiasm superiorly, and on either side is the cavernous sinus with the internal carotid artery within the cavernous sinus. Inferiorly is the sphenoid sinus. So this is the pituitary gland with the juxta-sellar structures and these anatomical structures. The relations between the pituitary gland and the surrounding structures: inferiorly there is the basisphenoid and the sphenoid sinus. Superiorly, as we saw, there is suprasellar system, the optic chiasm and the diaphragma. We'll talk about the diaphragma shortly. Laterally, on either side, there are the cavernous sinuses. Anteriorly, there is the anterior intercavernous sinus, and posteriorly, the posterior intercavernous sinus. This is another image showing the pituitary gland here, the optic chiasm here, the supraoptic recess, the infundibular recess, and this is the mammillary body. So now we know the normal structure of the pituitary gland and the surrounding structures, right? What do you see in this image? What's wrong with the sella turcica? Do you see any abnormality? Yes. Okay, I sure. I go back to the normal. Okay, I go back to the normal. This is the normal. Or I find more clear one, right? Or this one. This is the pituitary gland. This is post-contrast. This is pre-contrast. The anterior area is iso-intense. The posterior is bright spot, right? And this is the infundibulum. So, what do we see in this image? This is sagittal plane. This is coronal plane. This is the sella turcica. This is the sella turcica. This is T1 MR image and this is T2 MR image. Can anybody tell any difference between this and the normal one? Where is the pituitary gland, by the way? Can you see it within the sella turcica? You don't see it, right? What is this thin structure, thin long structure here, flattened? This could be the pituitary gland, right? Okay. What about this signal intensity? It's not the normal signal intensity of the pituitary, right? Yes. But if you notice that it is iso-intense to the CSF, right? It's iso-intense to the CSF within the ventricular system. So this is mostly CSF, right? Yeah. This is a normal variation and could be a pathologic change of the pituitary gland. It's called empty cellar. Yes, empty cellar. So here we talk about the variations of pituitary gland. There is hypoplasia, hyperplasia, empty cellar turcica or partially empty cellar turcica, and duplication of the pituitary gland. The hyperplasia could be a physiologic or pathologic change. Physiologic change happens within the puberty stages, during pregnancy, during lactation. This is because of the overestimation of the pituitary gland. So it enlarges and there is hyperplasia of the pituitary gland cells, right, to produce the required hormones for these physiological changes. Then we talk here about the empty cellar. Before we talk about the empty cellar, we need to talk about the diaphragma cellar. Diaphragma cellar is a dura reflection above the sella turcica. It separates the sella turcica from the other structures of the blood. But it has small opening, that is the opening of the infundibular stalk. This is the pituitary stalk. Sometimes this opening is large. Sometimes there is incomplete formation of the diaphragma cellar. So the CSF will be introduced into the sella turcica. Therefore, it will cause deviation and flattening of the pituitary gland and causing what is called the empty cellar sign. This could be a normal variant, but some other pathologies can cause this change, including the increased intracranial pressure and herniations.
So it's not a pathologic side. Empty cellar is
Empty cellar, if it is asymptomatic, you will find it in not uncommonly, you know. Yeah, if it is asymptomatic, it's mostly a normal variant because of this incomplete formation of the diaphragma cella, or there is a large opening of the infundibulous stalk. So the CSF is entering the cella torsica. But if there is symptoms of increased intracranial pressure, headache, nausea, vomiting, like some other maybe herniation, if you see it on the images, so this probably a consequence of these pathologies. Yes. Then we talk about the cavernous sinus. This is one of the juxta-sellar structures. These are the paired dural venous sinuses. If you remember, we talked about the dural venous sinuses, right? One of them is the cavernous sinus. We will have a look at image to show the cavernous sinus with relation to the other dural venous sinuses. It's located on either side of the pituitary fossa and body of the sphenoid bone. The structures within the cavernous sinus, including some nerves and the internal carotid artery. This mnemonic here is maybe useful to remember the structures. It has the oculomotor nerve, like segments of oculomotor nerve, trochlear nerve, ophthalmic branch of trigeminal nerve, maxillary branch of trigeminal nerve, and abducent nerve. So this is the area of the cavernous sinus. It receives the blood from ophthalmic veins, from inferior petrosal sinus, from superior petrosal sinus, and from some intercavernous sinuses or intercavernous veins. So this is the cavernous vein, the cavernous sinus. This illustration shows the structures within the cavernous sinus, including the internal carotid artery, highlighted in red here. This one is the oculomotor nerve and the trochlear nerve here. The A is for the abducent nerve. The inferior O is for the ophthalmic branch of the trigeminal nerve, and inferiorly is the maxillary branch of trigeminal nerves. This is another illustration in coronal view. This is pituitary gland, right? And this is the stalk. This is the optic chiasm. And this is the internal carotid artery. It's passing through the cavernous sinus. So this is the cavernous sinus passing through, this is the internal carotid artery passing through the cavernous sinus, which lies on either side of the pituitary gland. So this is all about these structures, and then we are finishing the brain imaging. We will continue to have head and neck and other structures. Thank you.